This conference will now be recorded.
I'm audible, right? Can you hear me? Can you hear me?
Yes, sir.
Thank you. So as you can see in the image, the fight or flight response, which we experience in emergency situations, is usually maintained by the hormones released by the adrenal gland. The adrenal glands are located at the upper pole of kidneys, and these are retroperitoneal structures. These are retroperitoneal structures, and these are one of the highest perfused organs in the body. This per gram amount of blood that is received by the tissue is around 2000 ml per kg per minute, and they are mustard colored, and each of them weigh about 4 grams. And on cross section, you can see outer adrenal cortex and the inner adrenal medulla. Outer adrenal cortex and inner adrenal medulla. And the cortex functions in a different way, the medulla functions in a different way. This is because they have different embryological origins. Okay, cortex usually arises from the mesodermal tissue near the mesonephros at around 4 to 5 weeks of gestation. This cortical tissue is important for steroidogenesis. Steroidogenesis, the body's steroids are glucocorticoids, mineralocorticoids, and sex corticoids. Glucocorticoids, mineralocorticoids, and sex corticoids. Any disruption in these three hormones causes a various spectrum of symptoms. And coming to adrenal medulla, it arises from the ectodermal tissue of the neural crust. That is from the neural crust. That is, if this is just that. So, because it arises from the embryonic neural crust, any disorder of this adrenal medulla are almost nearly similar to various problems arising in the other neural crust origin structures. The various other neural structures that are originating from the neural cluster, neuroendocrinal cells. These neuroendocrinal cells are usually distributed in various parts of the body. They're distributed in the autonomous nervous system. They're also distributed in the pancreas, in the lungs, and so on. So any disorders here might arise over there. Okay. Example: pheochromocytoma, neuroblastoma, and so on. See, this is the cross section. The outer cortex and the inner medulla, they are structurally as well as functionally different from each other, and you can see the physical distinction clearly. This adrenal gland is an encapsulated structure. It has a capsule. Beneath the capsule is the cortex, and within the cortex is the medulla. Coming to the relations, the right adrenal gland lies over the upper pole, lateral to the inferior vena cava, and posterior to the liver. It is posterior to the liver, and the upper part indents onto the diaphragm. It indents onto the diaphragm. So any adrenal swelling might move with respiration, because this adrenal gland is in contact with the diaphragm. So do you remember, right? This any structure which moves with respiration is usually in contact with the diaphragm. Any abdominal structure which moves with respiration is usually in contact with the diaphragm. Okay, this is an important point in inspectory part of abdominal case presentation. Okay, so if any swelling which moves with respiration, you need to consider the adrenal swelling as one of the differential diagnoses. And the other swelling is a left adrenal gland. This left gland is semilunar in shape. The right is pyramidal and this left is semilunar in shape. It lies close to the spleen, and lower end reaches the renal hilum. And similar to the right, this is also in contact with the diaphragm. This is also in contact with the, that is in contact with the right crest, and this is in contact with the left crest of the diaphragm. Coming to the blood supply. The blood supply is by the superior adrenal artery, which is a branch of inferior phrenic artery. There are three arteries: superior, medial, and inferior adrenal arteries. The upper superior is branch of inferior phrenic, middle is branch of abdominal aorta, and the inferior is branch of renal artery. And there are two veins, the right and left adrenal veins. The right adrenal vein drains directly into the inferior vena cava, whereas the left adrenal vein drains into the left renal vein. Similarly, the other structures will directly drain into the left renal vein are the left testicular vein, and similarly the right testicular vein drains into the inferior vena cava. Okay, so any problem in the left renal vein will reflect as the problem of left testicular veins and left adrenal veins, because these structures drain directly into the left renal veins. In what conditions might this left renal vein be affected? As you can see, in the image, the superior mesenteric artery is or arises above the left renal vein, and it might get caught at the origin. Such a syndrome is nutcracker syndrome. When this aorta mesenteric angle is obliterated, it might damage the, it might occlude the left renal vein. So that is nutcracker syndrome. Coming to the adrenal cortex, as I have told, it is a capsulated structure where you can see in it the outer one is a capsule, and it is divided into three layers. To remember this, remember it as GFR: outer zona glomerulosa, middle zona fasciculata, and inner zona reticularis. Glomerulosa, fasciculata, and reticularis. And 80% of the adrenal gland is made of the adrenal cortex. Zona glomerulosa, it secretes the mineralocorticoids. The mineralocorticoids are aldosterone. It is important in water and salt homeostasis in our body. It is secreted in response to excess potassium, low fluid levels, low blood volumes, and low sodium levels. Okay, so that is why when do you experience low fluid and low blood volumes? Either in hemorrhage or in shock or in sunstrokes, where the fluid level is very low. So in such conditions, aldosterone, it increases water retention and blood volume. It increases interstitial levels of sodium, and it increases urinary excretion of potassium. That is why aldosterone antagonists are used in treatment of hypertension. Okay, understand that, because what is the problem with hypertension? There is excess sodium, or there is excess of blood volume, or excess of fluid. It is excess of pressure. So decrease this pressure, we need to counteract aldosterone. If we counteract aldosterone, the fluid levels will be low, the blood volume will be low, the sodium levels will be low, and thus there can be a lesser blood pressure. Next is the zona fasciculata. Zona fasciculata, it secretes glucocorticoids. Okay, cortisol. Cortisol is a very essential and important hormone in our body, without which we will not be able to survive. We need cortisol, and it has another problem. Excess of cortisol is also dangerous. Lack of cortisol is dangerous. Excess of cortisol is also dangerous. Okay, it is secreted under the control of adrenocorticotropin releasing hormone, which is from the anterior pituitary. It stimulates release of amino acids in the body. It stimulates lipolysis. It stimulates gluconeogenesis. See, by acting these three ways, it is providing nutrition for our various cells of the body. If this is not present, these three vital functions will not happen, and the patient is at a critical risk of immunosuppression or weakness. And coming to the next point, see that it causes hyperglycemia in response to stress. It increases water retention. It has high anti-inflammatory and anti-allergic effects. Okay. So see, when you see this last three things, last three functions, imagine a normal cortisol level maintains these three essential functions. So if there is excess of cortisol, what will happen? There is excess of hyperglycemia, that is diabetes. There is excess water retention, that is hypertension, and there is excess anti-inflammatory and anti-allergic effects leading to immunosuppression. Okay, so that is what I have told you. Excess of cortisol is dangerous. Excess of cortisol exaggerates the last three. Lack of cortisol uh, diminutes the first three. Okay, these six important functions are maintained by the cortisol. Then comes the zona reticularis. Zona reticularis release the sex androgens, sex corticoids. These are the androstenedions, dihydroepiandrosteredion, and so on. They are synthesized in adrenal cortex and liver, and this is also regulated by the adrenocorticotropic hormone. These are important for secondary sexual characteristics, that is, growth of pubic and axillary hair, and they play a role in libido and sense of well-being. The absence of these hormones leads to something called a pseudohermaphroditism. Pseudohermaphroditism. This absence of this might, you won't be able to differentiate between a male and a female. Then comes the adrenal medulla. The inner structure, this forms 20% of the adrenal gland. It is consisted of the chromaffin cells. It also contains various neurological structures because it arises from the neural crest. It secretes catecholamines like epinephrine and norepinephrine, or adrenaline or noradrenaline. These maintain the fight or flight response. Fight or flight response. Okay, when you see a dog, you run or you fight. So that is fight or flight response. And this function is maintained by the adrenal medulla. Epinephrine or the adrenaline, it increases heart rate, increases the force of contraction. That is, it is chronotropic and inotropic. And it facilitates blood flow to the muscles and brain. It relaxes smooth muscles. Okay. It facilitates blood flow to muscles and brain. So when you want to run or when you want to fight, you need you need to have intense focus and intense energy. This is provided by increasing blood flow to the muscles and brain, and it causes relaxation of smooth muscles, because if the smooth muscles are also functioning, they might also consume the blood. That is why the blood is diverted to the peripheries and the smooth muscles will relax. What are the smooth muscles? Smooth muscles are nothing but the muscles that are present in the GIT. The muscles that are present in the GIT. The only smooth muscle which is contracted in the body is the iris. The iris is contracted. If you give epinephrine, there is pupillary dilatation. Other than that, it is pupillary dilatation. Sorry, it is relaxation of smooth muscle. Okay, it relaxes with muscle. Example is pupillary dilatation. And there is the other hormone is a norepinephrine. It is nothing but epinephrine, but it has a stronger action. It is also vasoconstrictive and thus increases blood pressure. See, there are the various adrenal gland disorders. One is the adrenal disorders of the cortex. The other is the disorders of the medulla. The disorders arising in the medulla is the pheochromocytoma, and other disorders are neuroblastoma, pheochromocytoma, neuroblastoma, medulloblastoma, and so on. Neuroblastoma is the most common abdominal swelling in infant period. Most common abdominal swelling arising from medulla in the infant period. The various cortical disorders are again divided into congenital and acquired disorders. The congenital disorders are the congenital adrenal hyperplasia, congenital adrenal hypoplasia. Okay, adrenal there is hyperplasia, also there is hypoplasia. And coming to the acquired disorders, there is excess functioning of gland as in Cushing syndrome, which is associated with excess cortisol, and there is Conn syndrome, which is associated with excess aldosterone. Cushing's is excess cortisol, Conn's is excess aldosterone, and then there is adrenogenital syndrome. Coming to the functional deficiencies, there is Addison's disease, lack of hormones, defect in aldosterone synthesis, defect in aldosterone action, and hyporeninemic hypoaldosteronism. Renin is a hormone secreted by the kidneys, and this is condition with there is less renin, and thus there is less aldosterone. In other, the RAS system, renin angiotensin aldosterone system, that is affected in this hyporeninemic hypoaldosteronism. And then there is tumors, adrenocortical carcinoma and incidentaloma. And the other tumors are adenoma, adrenocortical carcinoma, incidentaloma. Okay. For this class, we will discuss the adrenal medullary disorders. Only this condition is important in surgical point of view. There are other disorders you will read in medicine. So this is pheochromocytoma, also called the 10% tumor. We also call the 10% tumor. That is 10% females, 10% malignancy, 10% incidence, and so on. There are this tumor arises from the chromatin cells which produce catecholamines. It was published by Felix Frankel in 1886. See, as I told you, it is 10% tumor. That is, it is 10% bilateral, 10% malignant, 10% extra-adrenal, and 10% familial. And these various symptoms are hypertension, headache, sweating, palpitations, hyperglycemia. 1 minute, please. Prithvi. వస్తాను ఏ వార్డులో ఉంది 119 అంటే దేనికి వైపా థర్డ్ ఫ్లోర్ అంటే ఓటీ వైపు పృథ్వీ అదేలే సైకియాట్రీ గైనిక్ అదే తెలుసులా వాటి తెలుసు ఓకే ఓకే వస్తారు కారణంలో వస్తారు అక్కడ ఉండండి పేషెంట్ ఉండదు కదా పృథ్వీ పేషెంట్ లేకపోతే అలాగే కేసీ లేబర్ మరి ఓకే hypertension, headache, sweating, palpitations, hyperglycemia, weight loss, nausea, and psychological effects. And the hypertension, headache, and sweating is the classical triad of pheochromocytoma. Okay, to diagnose, the first test you must do is a plasma-free metanephrine. Metanephrine is nothing but adrenaline or noradrenaline. And then you go for 24-hour urine metanephrine and catecholamines. Okay, see, that means I am mistaken. Metanephrine is a precursors and successors of catecholamines. And if plasma-free metanephrine is positive, go for 24-hour urine metanephrine and catecholamines. And if it is positive, you go for CT or MRI. CT or MRI you have to do because you have to know the extent, and you have to know for as I told you, 10% are extra-adrenal. So you have to find out the 10% tumors also. For that, you go for a meta-ido-benzyl-guanidine scanning, MIBG scanning. Okay, to identify various to identify the multifocality. Okay, and if the 24-hour meta-interference and catecholamines is negative, you repeat the test again, and if it is positive, again follow the same CT-MRI cycle, and even if that is negative, then you go for the uh, even then it is negative, you observe it. If it is mild to moderate positive, then you go for clonidine suppression testing. Clonidine suppression testing is clonidine suppression testing. If the norepinephrine is suppressed, if norepinephrine is suppressed, then you can observe. But if it is not suppressed, again you follow the CT-MRI cycle. Okay, this is the first one is the MIBG scan. You can see the hotspots. See the in the head, the hotspots being the parotid and the sublingual glands, parotid and the submandibular glands, parotid and the submandibular glands, and you can see liver. Then you can see the adrenal glands and some of the skin in the urinary bladder. Okay, and MRA, the classical appearance of pheochromocytoma is Swiss cheese configuration. You know what is Swiss cheese? Okay, it's a cheese with multiple holes in it. Okay, similar appearance in a Swiss cheese appearance on top. So in this condition, CECT or CEMRA is better, and the contrast usually used is the MIBG, meta-ida-benzyl guanidine, and it is more specific for the sensitivity. It is more sensitive and specific for pheochromocytoma. And the problems with then, if you make a diagnosis of pheochromocytoma, you need to go for surgery outright. Outright, you have to plan for surgery. But the problem with pheochromocytoma is there is high fluctuations of blood pressure in peri-op period. Peri-op period ante within 24 hours from the onset of surgery. 24 hours from the onset of surgery. That is intraoperative period and immediate 24 hours. Okay, and so the various stimuli for intraoperative hypertension due to excess catecholamine release are: one is anesthesia inducing drugs. Anesthesia inducing drugs. Okay, certain anesthetics might induce catecholamine release, and there is something and there is direct manipulation of tumor. When you handle the tumor, you might release you might release the hormones which is contained within the gland. Okay, then when post-operative hypotension, sudden withdrawal of these hormones might lead to sudden onset of hypotension, which is drastic, and the patient you might collapse, and you might lose the patient within seconds. So you need to keep in view of all these conditions, of all these problems, and you have to manage accordingly. Okay, so how do you do it? First, so in our body, blood pressure is maintained by beta receptors, alpha receptors. Okay, adrenergic receptors, we know there are two types: alpha and beta receptors. Okay, so what you have to do is, if you use beta blockers, there will be unopposed alpha action. Okay, which is very dangerous than beta action. So that is what you have to do is, initially block the alpha receptors are blocked initially, then you go for the beta blockers. Okay, remember this: first you use alpha blockers, then you use the beta blockers. A B, alpha, beta. The alpha blocker that we use is the phenoxybenzamine 10 mg BD, means twice. BD means twice daily. This achieves normal, this maintains normal heart rate and blood pressure, and should be given at least 2 weeks, for reversal of. And after, even after surgery, you have to continue this for at least 2 weeks. Sudden stoppage of the drug leads to excess adrenal activity, excess alpha adrenergic activity, and there will be malignant hypertension. That is why you need to taper it off for at least 2 weeks. Okay, once you have blocked the alpha, how do you know that you have blocked the alpha? The patient will have dizzy mind. He will have a dizzy mind. So that is when you have to go for beta blockers. When sufficient alpha blockade is present, then you go for beta blockade. Okay. And beta blockade, with it is usually used with patients with persistent tachycardia despite alpha blockade. Okay, this statement is wrong. Anyway, after alpha blockade, you have to give for a beta blocker. Alpha and beta both are must. Okay, remember that. Give alpha, control BP, then start beta. This is the sequence. Remember that, because this is an important 2 marks question for you. They will ask you these questions. So remember the drugs. Okay. So for any, and then going to the surgery. So first you have to read whether it's a benign malignant, because 10% are malignant. If it is a malignant, you should go for radical surgery. Just as it is, if it is benign, just you can go for an adrenalectomy. That's it. Usually, laparoscopic resection is the treatment of choice. As of now, any surgery, laparoscopic surgery is a treatment of choice for any kind of surgery. Okay. If the tumor is more than 8 centimeters, better go for an open approach. Better for an open approach, either be a retroperitoneal approach or an via the intra-abdominal approach. Okay, retroperitoneal you give incision over the back, intra-abdominal you give the midline incision. And while doing surgery, as much as possible, try to minimize the manipulation of tumor. Try to minimize the manipulation of tumor. Then there is malignant pheochromocytoma. As I told you, 10% are malignant. The survival is 20 to 40%, and the metastases are to the lymph nodes, bone, and liver. Okay. Treatment is surgical excision or tumor debulking. And once you have done a malignant adrenalectomy, you have to follow the patient with radiotherapy and chemotherapy. And once you have started this treatment, you have to follow the patient at around 4 to 6 weeks with an iodine 131 MIBG scan to know for any distant metastasis, or a local recurrence, to see for distant metastasis or a local recurrence. So this is about pheochromocytoma. And then there is incidentaloma. Incidentaloma, as the name suggests, incidentaloma is that the patient will not have any symptoms. So when you are scanning for certain other problem, you find this swelling, and such swelling is called an incidentaloma. That is, incidentally you have found this. Other than that, the patient is doesn't have any symptoms. It doesn't have any problems. Okay, such swelling is an incidentaloma. The incidence is 1.4 to 8.7%. It is around 1.5 to 8%, and this increases with age. And 75% are non-functioning adenomas. 75% are non-functioning adenomas. But the other swelling might be a Cushing's adenoma, pheochromocytoma, or a metastatic lesion. And the most common cause of mets to the adrenal gland is the breast. Breast is the most common cause of metastasis to adrenal tumors. Breast. Okay, remember breast. Other metastases are might be from the thyroid. Most common is from the breast. Other metastases might be from the thyroid, breast, thyroid, and so on. Breast, thyroid, and lung. So, okay, how do you investigate adrenal incidentoma? Adrenal similarly, you go for a 24-hour, just like pheochromocytoma, you go for a 24-hour urine metanephrine and catecholamine assay. Then you go for a low-dose dexamethasone suppression test. Then, if these are positive, if it is, we will know whether it is a functional adrenal tumor. Okay. If it is a functional tumor, you outright go for a adrenalectomy. Adrenalectomy. If it is not functional, consider the size. If it is go more than 5 centimeters, go for adrenalectomy. If it is less than 3 centimeters, you can follow up the patient with the help of CT in the next 6 months. And if the size is between 3 to 5 centimeters, uh, look for the following features like: is there any suspicious imaging activities? Is there any, if the patient is, if the patient has less surgical risk factors, and there is interval tumor growth, and if there is, and the patient preference, and if these 5 factors are yes, go for adrenalectomy. Yeah, and if these are no, you can manage the patients. You can scan the patients every 6 months with the help of CT and follow up and have follow up about the patient. Okay. In terms of adrenal, this is what you need to know. And there is adrenal cortical carcinoma. Um, it is more common in females, mostly in the children. It has double peak. One peak is in the childhood, one other peak is in the fourth and fifth decades. It is a non-functional tumor. The symptoms usually might be of compression of the kidney, involvement of inferior vena cava, and abdominal lump, back pain, and so on. If it is a functional tumor, it might have some symptoms like Cushing syndrome or Conn syndrome. On CT, the investigations you must do are the CT scan of the abdomen, CT scan of the chest, and MRI is more sensitive than CT. And if it is a functional tumor, you have to assess for the hormonal levels like DHEA, cortisol, catecholamines, and so on. You need to rule out a pheochromocytoma. And there is something called a McFarlane staging system. Um, this is McFarlane staging system. Stage 1 is less than 5, stage 2 is more than 5, stage 3 is locally invasive, stage 4 is distant metastasis. And treatment will be an adrenalectomy. Because it's malignancy, it is a radical resection, that is en bloc resection of kidney, adjacent organs, meaning kidney and surrounding fat and regional lymph nodes. If there is incomplete resection, there is the lifespan decreases very much. The median cellular will be less than 1 year. So you need to go for a R0, that is complete resection. R0 means complete resection. Even though you have gone for an R0 surgery, the patient is prone to metastasis and local recurrence, which is within 2 years. That is why you have to go for chemotherapy and radiotherapy for this patient. The chemotherapy we use is the mitotane drug, mitotane, which is a direct adrenocortical toxin, and adjuvant radiotherapy. Adjuvant means along with chemotherapy, giving radiotherapy is called adjuvant radiotherapy. So chemotherapy with adjuvant radiotherapy. Okay, and the poor prognosis is associated with if the older the patient and poorly differentiated tumors, positive margins, and distant metastasis are associated with poor prognosis. Okay, so these three are important in point of adrenal for your age, that is for your class. Other than that, you need not know much in terms of surgery. Okay, incidental pheochromocytoma, adrenocortical carcinoma, and rest other adrenal disorders will be discussed in medicine topic. Okay, anyone have any doubts? If so, we can end the class. No doubts, right? I'm taking that as an S. Okay, thank you. That's the class for today.